Good morning, one and all. I welcome you all to the session 2, the Cornea Preferred Practice Guidelines Update. I invite our respected expert panel, Dr. Rajesh Fogla, Dr. Sayan, Dr. Kuresh Maskati, Dr. Vanati M, Dr. Revati Rajaraman, and Dr. Ratika Tandon. Let's talk. The first talk of this session is by Dr. Ratika Natarajan, Non-Healing Corneal Ulcers, the Preferred Practice Guidelines.
Good morning, I am Radhika from Shankar Netralia. So, a corneal ulcer may not be healing because of multiple reasons. Either it may be a very virulent organism, or the organism may be resistant to the medication, the infection may be very deep in location, the patient may not be very compliant with the treatment, there may be many bugs that are involved, or it may not be an infection at all. So, let us see some clinical situations of each of these. Here you have a deep fungal keratitis where you can see in the slit picture that the infiltrate is almost forming an endothelial plaque. So, we know that the antifungal agents being lipophilic are not going to reach there. So, this patient will not do well just with topical treatment, and after multiple intrastromal injections you can see that the ulcer is resolving, as you can see in the picture below. Here this infection does not look that aggressive, but this is a stubborn infection. This is a demititious fungus called Cladorhinum species, of which we have reported 4 cases. So, this slide is to show that even though it is not very aggressive, this takes a very long time to resolve. So, patient observation with the usual antifungals led to resolution, as you can see in the second picture, over 4 to 6 months period of time. So, that much of close observation is required before declaring this infection as non-healing, because these seldom require therapeutic keratoplasties. So, when you have a resistant infection, it may be worthwhile doing a re-scraping. There are some points to be kept in mind. A drug holiday sometimes helps. You have to scrape the leading edge of the ulcer, as you can see in picture B, because if you scrape the part which is pointed with the arrow, then you will get only scarred bits and epithelial tissue. You won't get the organism at all. And post scraping, you have to measure out the epithelial defect, because healing of that is integral to healing, especially in bacterial keratitis. And in the last picture C, you can see a whitish scar-like lesion, but then you see that the eye is injected, it is not quiet. So, sometimes whitishness can happen even with active infiltrates in microsporidiosis acanthamoeba type infection. So, white is not always quiet in the context of corneal ulcers, that must be remembered. So, here is a mycobacterial sclerokeratouveitis. This is an infection definitely, but you see multiple pus points in the sclera and uveitis. So, there is a definite component of inflammation as well in this entity. So, the treatment is not only consisting of topical amikacin, you should give systemic antituberculous agents as well as steroid, and only the combination of 3 will bring about a resolution in this particular clinical picture. In Pseudomonas ulcers, steroids used to be a taboo earlier. But see this particular patient, the first picture shows the active stage. The second picture is when it has been treated with high concentration levofloxacin. The disease is simmering down, but still it is an angry eye. This is the right time to introduce steroid judiciously, with which you can see that with the minimal scarring and vascularization, the resolution happening in the last picture. So, viral keratitis is one of the entities where infection and inflammation coexist. We must know about this before declaring that the infection is not healing. Here you can see the immune ring in herpetic stromal keratitis, and this kind of presentation, stromal necrotic keratitis, requires therapeutic dose of antiviral and therapeutic dose of steroid to bring about a resolution, which you can see in the next picture. So, sometimes the infection is not healing because we are not recognizing it. This is a post-keratoplasty situation in herpetic eyes. When it comes on very early, it is not a recurrence, because the virus comes along with the nerves which are growing back. But see these late examples. Here you have 2 characteristic features. You have an epithelial defect which is straddling the graft-host junction, and it is also staining with rose bengal in all the cases. So, these are 2 indications that this is not just an epithelial defect, this is actually the HSV coming back, which requires treatment then accordingly. On the other hand, take a look over here. This looks like a marginal ulcer. You can see a typical lucid interval. You can see those minimal infiltrates which are multiple in nature. But then in marginal keratitis, the eye is seldom this inflamed. Here it is a suffused eye with diffuse congestion. This is in fact HSV. This is HSV blepharokeratoconjunctivitis. How you can distinguish this from marginal keratitis? In marginal, you have a dry blepharitis with a very minimal infiltrate. Here you have an angry ulcer with an injected eye. You should know the difference. Then because if you treat it as marginal with steroid, HSV will flare up. So the treatment over here is with antiviral agents. So how do we know whether there is an immune component or an inflammatory component, an immune component or an infective component when you have a corneal ulcer? There are two simple rules. One is the epithelial defect comes first in an infection. The infiltrate comes on later. Whereas in an immune disease, you have infiltration of the stroma and then the epithelium breakdown on top of it. Secondly, as you can see in the center picture, that is a Pseudomonas infection. You have a massive infiltrate, but the cornea has just about started melting over there. Contrasted with that Murren's ulcer in that corner, there is a lot of melt but very less infiltration. So infiltration is always more in infection and melt is always more in immune disease, even though the two can sometimes coexist. Sometimes there are triggers which we need to address before labeling as non-healing corneal ulcers. Here the patient is constantly on NSAID for pain relief and you can see the burrowing that is happening in the cornea. In this patient, the ulcer heals and breaks down, heals and breaks down. That is because you see the eye is not closing properly and you need to address that so that it will not recur. This is a patient in whom a bedside tassuraphy has been done in a very debilitated patient, but it has become counterproductive. You can see that the sutures and the bolster, everything are very badly applied. Bedside is difficult to apply, I agree, but these are poking on the ulcer and preventing it from healing. Also here there is a definite component of neurotrophic keratitis. You can see the unhealthy base and the unhealthy margin. There is no infective component over here. So here we have used a PROS contact lens very efficiently in bringing about a resolution. So sometimes we also need to know when to stop treating. So here is a patient who has healed completely. This is in fact a pseudocornea, which is nothing but a healed scar with epithelialized iris. So there is no infection to treat over here. What we need to take care of is keep the IOP under control from inside, from within, and avoid trauma from without, and there will be no reactivation of the problem. So sometimes the ulcer is labeled as non-healing because it is not an ulcer at all. Let me show you a couple of quick case examples. The top panel shows a patient who was referred to us with an infection following a lamella tear injury. So, but if you watch closely, the flap is necrotic because it is lifted away from the bed. So there is no nutrition to the flap. And because it's a young patient, all the inflammation is outpouring a hypopyon over there. So all we did was, like in a LASIK flap, open it up, clean it nicely, de-epithelize it, put it back and suture, and with steroids you can see that the so-called infection was only an inflammation which has resolved nicely over there. The picture below also was referred as a patient post-CXL with infection. But then you see that there are multiple infiltrates, they are whitish, they are along the circle of the riboflavin dye and the de-epithelialization that we do, and there is no epithelial defect on top. So the lack of epithelial defect and small whitish infiltrates, you know that that is a dye reaction, and again you can see in the subsequent picture that steroids have brought about a resolution. So non-resolution here is because there was, first of all, no infection at all. Here is yet another patient who was diagnosed with herpetic keratouveitis. You can see the star-studded capes in the cornea over there. But then, hold on, there was a flocculent cataract. What kind of HSV produces flocculent cataract? We got a history of trauma from that patient, and you can see where the arrow is pointing, there is a little breach in the capsule. This is in fact a phacolytic uveitis. So what is the difference? In herpetic keratouveitis with a cataract, you need to subside the uveitis before doing the cataract surgery. Whereas here, doing the cataract surgery under steroid cover is the treatment. It should be done primarily, which then brought about the resolution in this particular patient. I'd like to close with this last and favorite slide of mine. This is a young girl with a systemic disorder in the form of lichen planus, which was not treated very well. She developed a bacterial corneal ulcer like any other. We scraped her, streptococcus positive, and she was on adequate medication. She was healing. And then with healing came vascularization, as you can see in picture B. When the ulcer was active, there was no melting, but the vascularization, because of the hyperimmune status of the patient, brought about with it melting. So we actually had to recess the pannus, which is seldom done in infectious keratitis, and then in picture D, you can see that the infiltrate is scarring down. So goes to show that when two diseases are in play, both need to be taken account of. Otherwise, it could be labeled as non-healing, and the course of the disease may differ. So with that, I wrap up my presentation and open to questions, and thank you very much.
Thank you, ma'am, for your comprehensive talk. I would like to ask Dr. Revati ma'am's comment.
Thank you, ma'am. PTM keratitis. Correct. Yes, ma'am. Actually, I have very typical pictures of a pythium keratitis causing a peripheral melt to be contrasted with a Moran's ulcer causing a peripheral melt. So, like I already touched upon in my talk, we need to weigh in besides history and the way the disease progresses. These are all indicators, but what I take as the most important factor is the relation between the infiltration and the melting. So, I always believe that infiltration is a very major component of infection. And the melting comes later when the keratocytes are eaten up by the organism. Keratocytes are eaten up because of the immune response caused by the organism. Whereas infiltration is not that prominent in a primarily immune disease. You have a little bit of infiltration and the guttering happens much more prominently in a Moran's ulcer. So if I see, I have the picture somewhere, not right now in my presentation, the pythium keratitis which causes the peripheral gutter, even though it may not have the actual features of pythium like your endoexudate or your tentacles on the periphery or reticular nature of infiltrate, you will have a lot of infiltration in the cornea. You will not have a quite cornea and just a peripheral melt. So that may give you a clue that you are dealing with an infection. There is a third type of presentation also. You have immune melt, you have infective melt, and you have immune melt with a secondary infection. So that is a third way in which you can have a melt presenting. There again you will see the gutter coming on first, and then there when the infiltration happens, it is not very angry. You just see a little yellowish or a whitish base, which then may be scraped and antibiotic may be added. So these are three different ways in which you can have the clinical picture. Totally agree, ma'am. The overhanging edge is a pathognomonic feature in Moran's ulcer, number one, and it is for diagnosis. And treatment-wise also, I'm glad you touched upon it. It is very important to debride that overhanging edge because it is a source of inflammatory material, and B, it is a source of non-healing. The epithelium will never bridge the ulcer no matter what you do when that overhanging edge is there. So you need to debride it to be able to bring about resolution.
Yeah. Thank you so much, ma'am. Any further comments? Otherwise, we'll move on to the next talk. Is Dr. Nidhi Gupta there? Or Dr. John
so
is going
ARC,
to...
Dr. Chitra and Dr. Anaga. Lovely to be here as usual.
Thank you so much, ma'am. You have always been a very important part of our ARC webinars.
Thanks, Anaga.
Thank you so much, ma'am. Inviting Dr. John. Please come, sir. He'd be speaking to us on peripheral ulcerative keratitis, current guidelines in medical and surgical management in the preferred practice guidelines.
A very good morning to all of you. Dr. Nidhi was absent due to some of the emergency, so I'll give in the talk. She requested me 2 days back, so the slides is made last 2 days. So I need your inputs if you need add on it later on discussion. So I'll be presenting peripheral ulcerative keratitis. I have no financial interest. So in your busy phaco and refractive OPD, if the patient comes like this condition, or if you are a slow practitioner, sometimes really we are confused. What exactly the problem all those eyes? Why it is so bad? And when should what should I give those patients, and when should I refer the patient? The smart answer all those conditions is that peripheral ulcerative keratitis or PUK. So what exactly the PUK? A group of destructive inflammatory disease involving the peripheral cornea, whose common final pathway characterized by sloughing of the peripheral corneal epithelium and keratolysis as a result corneal melting. So why exactly the peripheral cornea is susceptible for the PUK? It is a highly vascular zone associated with the lymphatic tissue, and the change of the collagen pattern for the corneal collagen and the scleral collagen and the limbal stem cells. And there is a tight packing of the collagen changes in the scleral collagen pattern. The vascular arcades, mainly the anterociliary arteries, accompanying lymphatics, high concentration of Langerhans cells and IgM and cyclosporin, and the immune component, and the collagenous and proteoglycans abundance. So as a result, inflammatory reaction in the corneal periphery, immune complex deposit and complement activation, and as a result, the immune vasculitis, and that causes the further increased vascular permeability and causing the leakage, and generate the chemotactic factors for neutrophil and the pro-inflammatory cytokines. As a result, there is cytokine storm is there. Neutrophil recruited and the peripheral cornea liberate the proteolytic and the collagenolatic enzymes and metalloproteinase production by the local resident cell, and as a result destruction of the peripheral corneal stroma. So that's the classification of the PK. Majority of the local and the systemic are immunological process, and a few cases are infectious. Among the ocular causes, the non-infectious are mainly idiopathic, Morin's ulcer, acne rosacea, and the marginal keratitis. Among the infectious, the staphylococcal, streptococcal. Among the systemic causes, the non-infectious one, the rheumatoid arthritis, among the under the headings of the collagen vascular disease, the ANCA-associated vasculitis, Wagner granulomatosis, and among the other systemic autoimmune disorder, Sjogren's one, and on the infectious was under heading of systemic, the gonorrhea one of the cause, and the tuberculosis, and the varicella zoster. Excuse me. What are the ocular manifestations? Sometimes the patient presents non-specific, and sometimes the patient presents the foreign body sensation, watering in the mild cases with the pupil erosion, ulceration, pain in severe cases associated with scleritis, pain without the scleritis involvement, the Morin's ulcer, disease decreased vision when the inflammation process proceeds centrally, and a photophobia with the reduction of the vision if the associated with anterior uveitis. On slit lamp examination, we'll get the panel. These are the spectrum of the patients which are having the infective PUKs. These are if you have to notice the patient having the lid margins and the tear meniscus, and the if it associated with the PUK, and you can see this patient obvious gutter formation is there. This is the peripheral ulceration with the gutter formation and profuse vasculation and thinning of the cornea. Even sometimes the patient have an embedded foreign body is there, impending perforation, or the patient present may be like this condition. On even the patient with the PUK with the persistent on and off history never miss the diagnosis to the examination of the lids. This is a sequelae of the acne rosacea. On never miss the foreign body. Even sometimes the patient presents with the PUK persistent, and maybe the leading cause of the underlying the foreign body could be the possibilities of the PUK. And Morin's and the sequelae of the honor of history with may be present first time with the, for the cataract surgery like this with clinical features. So what will be the diagnostic tools for the PUK? Excuse me. A thorough history, contact lens were current, and the previous medication for the disease and the trauma and the surgery. A comprehensive systemic review to rule out the systemic disease and associated PUK. A complete ophthalmic examination to exclude the local pathology is essential. When you suspect the infected, corneal scraping should be done, gram and kVH on culture, and rapid reliable test and prompt selection of the antibiotic if needed, indicated. If non-infectious, and routine all cases of suspected PUK, do the CVC, C-reactive protein, and R effector, anti-neutrophilic antibodies, and thyroid function test, and C-ANCA for the granulomatosis. What is the management? What is the preferred practice pattern for the PUK? Treatment of the underlying infection present, medical management, mainly by the topical steroids or topical immunosuppression, systemic steroids, systemic immunosuppressive therapy, additional surgical procedure, and the rehabilitation of the patients. Excuse me. Medical management, antimicrobials if infection are suspected, prophylactic topical antibiotics to prevent the prophylactic topical antibiotic to prevent the secondary infection, enhance the lubrication which dilutes the effect of inflammatory cytokines to therapeutic tear film, cycloplegic if there is a pain is there, AGM when suspected the shoot of IOP, and topical cyclosporine when you suspect patient they need long-term immunosuppression. Topical corticosteroid considered the initial therapy for the milder unilateral cases, useful in mild cases of the RA associated with PUK, loteprednol 0.2%, fluoromethanol 0.1%, prednisolone acetate 0.5 to 1%. Systemic collagenase inhibitor in the form of doxycycline when you think the patient needs the collagenase inhibitor, and for the adult patient and for the pediatric patient azithromycin or the erythromycin should be considered. With the systemic corticosteroids, excuse me, oral prednisolone 1 mg per kg per day, very commonly managed, but for the more severe case of the PUK, if there is a progression, pulse methylprednisolone 0.5 to 1 mg A single dose may be effective. Corticosteroid alone may be inadequate to control the progressive ocular disease process. Prolonged use of corticosteroid should not be considered. Then you should think for the systemic immunosuppression. Immunosuppression therapy in the form of methotrexate 7.5 to 12.5 milligram weekly dose, azathioprine or cyclosporin A 2 milligram per kg per day, MMA 500 milligram BD or cytotoxic agents such as cyclophosphamide 2 milligram per kg per day have been demonstrated clinically effective for the inflammatory eye disease. Indication of the immunosuppressive in FUK, bilateral or progressive Moran's ulcer, unresponsive to aggressive conventional medical or surgical therapy, associated with potentially lethal systemic vasculitis, symptoms such as the PAN, RA, SLE, ESS, Sjogren's, and the Wegener granulomatosis, Chastros, and the granulomatous chronic arteritis associated with the nucleotizing arteritis and vasculitis confirmed by the histopathological analysis of the ocular tissue. So what next? The biological agent. I will take just
excuse me,
wrap
sir.
up
Yeah.
the things.
Can you please?
So some of the immunomodulators are there for the specifically. So if there's perforation is there, what will this approach? If there's a small perforation, you can make the globicil. If it is very small, less than 3 millimeter, you can plan for the AMT or tendon plasty. If it is more than 3 to 5 mm, it should be the conjunctival recession and hooding along with the LK or PK. For the long-term management, which should be better? Is immunosuppression definitely is better than the compared to the oral steroid. These are the relevant study. Please go through it. It will be immense help for your day-to-day practices. So I'm just sharing some of the very shortly. Just some of the patient. This lady will tell it. The party came with one night patient came from the Bihar with the history of the melting. So simply we have done the glue whistle for this thing and started the pulse, IVMP and the oral and sent the rheumatologist. And you can see the immense good result. These are the patient, the PUK associated dry eye
Sir,
disease.
can we please sum
10
up, sir?
things and some of the things. So like find out the things why what exactly the you are going for, and if you are planning for the cataract surgery, eye should be quiet, it should be under the immunosuppressive and the oral steroid coverage, should not doing any venting incision or incision through the thinner part, and it should be done under the when the eye absolutely quiet. And just I'm just some of the things. PUK is one of the leading cause of the chronic eyes waxing and waning courses. Specific clinical diagnosis is most important to address the leading cause, rule out the underlying autoimmune disease, judicious use of oral steroid in long run, choose appropriate immunosuppressive irregular monitoring. Management of the corneal perforation depends on site, size and shape and location. Causes the perforation, tenonplasty is upcoming. Post PUK phacosurgery, no surface inflammation should be there underlying under the immunosuppressive or oral steroid coverage. Don't hesitate to refer the complicated PUK patient when not amenable by yourself for the long-term benefit of the patient and to salvage the eye. Thank you very much.
Thank
Thanks
you
for
so
your
much,
patience
sir.
sharing. Just taking the advantage that's I just on the behalf of OSWB welcome all of you for the next 2024 AIOS of Kolkata. I invite you all, please come for the City of Joy. Thank you very much. Thanks ARC for the giving me the opportunity.
Thank you so much, sir, for a good, excellent presentation. By the time Dr. Rishi loads his presentation, any quick comments from Dr. Radhika ma'am?
I think he covered everything extensively. Important is to take help of systemic treatment and make sure you're not missing active systemic disease. Very, very rarely it happens that they have a known systemic disease which is quiet, and then you have this tussle with the physician who sometimes they're happy to start, otherwise they say not from the systemic point of view, and then you as an ophthalmologist has to start the treatment if there's a very difficult
Exactly,
kids are
ma'am. I
waxing and
just
waning.
agreed with you. Similarly, I think we have presented one patient. The lady came with us during the COVID time, and it was looks like the patient having the the first presentation was the periorbital cellulitis. So physician was very reluctant to start the oral steroid. So sometimes it's very dilemma is that, but if you are clinically, your grammar of the surgery or everything, if you are clear in your mind what I'm going to do, then it's very easy to manage the things. Thank you very much. Thank you.
Thank you so much. We'd like to now invite Dr. Rishi to give his talk on collagen cross-linking. Where are we? And it will be a 6-minute talk with a 2-minute discussion. And Dr. Geeta here would be next. If you can please be ready.
Thank you. This is a very difficult topic to finish in 6 minutes, but I'll try to be fast. Okay, so this is just an update of where we are with cross-linking. As we all know, just like phacoemulsification, we've got this idea also from our dentists who use it to kind of solidify tooth fillings. We are using UV light and riboflavin and oxygen to kind of cause a cross-linking of the anterior stroma. The ideal indication have enough evidence to show whether they really are useful in these indications or not, but can have been tried and can be tried. The three main elements in cross-linking are the UVA light, oxygen, and the use of riboflavin. And it is the interplay of all of these which really helps you to understand whether cross-linking works or not. There are several protocols that have been described, and we have to understand how to navigate this sea of protocols. The conventional procedures is the standard Dresden protocol, which is described by Wolensack et al., which involves the use of 0.1% riboflavin for 30 minutes after removing the epithelium, followed by 30 minutes of UVA irradiation with a wavelength of 370 nanometers and a power of 3 milliwatts per centimeter square, which comes to a total energy of 5.4 joules per centimeter square. So you remove the epithelium more than 7 millimeters for this, and then follow these steps as I have just mentioned. Okay, that's just a video showing the different steps. You have to do a calibration first, remove the epithelium, instill riboflavin up to 30 minutes, and then 30 minutes of UVA. Now, there is something called the Bunsen-Roscoe law of photochemical reciprocity, in which the premise is that if you maintain the same the total energy, even if you increase the irradiance intensity and reduce the interval, as long as the total energy remains the same, it should be fine. So you could use theoretically any of these protocols and still have 5.4 joules per centimeter square being delivered on the cornea, and it should equally work. But studies have shown that that's not really the case. The accelerated protocols do work, but they work less efficiently from the biomechanical effect and even from the demarcation level line point of view in these corneas. So especially for higher irradiance levels, it doesn't work as well. So 9 milliwatts per centimeter square for 10 minutes is what most of the people are using in accelerated protocols, because it gives you a slightly reduced effect, but reasonably well, because you are able to save a lot of time. So in general, avoid accelerated protocols in the ones where you really want a good cross-linking effect, like pediatric eyes and post-LASIK cross-linking. This is another study from the Narayan Netralaya group, which showed a similar kind of outcome, that the accelerated of 9 milliwatts for 10 minutes is working almost as well in terms of the demarcation line being the outcome measure. So Quinones et al. Did a slight modification to overcome for this loss of effect, and instead of 18 milliwatts into 5 minutes, they are doing 18 milliwatts into 7 minutes, which delivers a total energy of 7.5 joules centimeter square instead of 5.4, and they have shown that this works almost as well as the Dresden protocol without significantly damaging the endothelium, and has similar deep demarcation line like a Dresden. So this may be a good trade-off, because you're using only 7 minutes of your time, and most accelerated machines will give you 18 milliwatts option. Epi-on cross-linking was tried for a while, but the problem with this is that not just the ability of the riboflavin to go in, the oxygen also should be able to reach the target site, and through the intact epithelium, the oxygen doesn't reach so well. So to a large extent, it's been given up. To make this work, people have tried using electrical current, using a procedure called iontophoresis. But again, for this you need separate equipment, so most of us are not having access to this or doing this. But there have been studies which show that it works quite well. Again, the disadvantage here is oxygen cannot cross the intact epithelium. So thin cornea cross-linking is another area which has been of interest, because many of our patients don't come in the early stage, and many things have been tried: hypotonic riboflavin, contact lens assisted by Susan Jacob et al., tissue augmentation using an island of epithelium at the thinnest area, etc. But I think the one which is now largely being used is the adapted fluence. I'll just move to that in the interest of time. It was described first by Hafezi et al., and then the Narayan Netralaya group has also described this calculator called the NXT calculator. And with this, basically, you are reducing the amount of time that you're giving using Hafezi's group was using 3 milliwatts per centimeter square, but I think the Narayan Netralaya group is also using an accelerated protocol. And basically, you reduce the time and reduce the total energy depending on the thickness of the cornea, and they have a calculator or a table to follow for that. So you can go as thin as 220 microns. So this is the NXT calculator from the NN group. You just put in the thickness and then it will calculate and tell you how much duration for how much power. Topography guided cross-linking has also been combined with PRK has also been combined with cross-linking, and there have been two protocols. The Athens protocol involves the use of a little bit of topography guided PRK, whereas the Cretan protocol is more like a PTK, and basically you're shaving off about a fixed amount of epithelium from the surface, and because the cornea epithelium is thinner in the area of the cone, you will shave off a little bit of the stroma at the steepest point, which has a flattening effect and gives a decent outcome. Now, the other things also have been described, PRK, LASIK extra, SMILE extra, but very little evidence. Pulse light cross-linking also has been tried. Customized cross-linking uses an enhanced fluence at the center of the cone, so it ends up causing a lot more flattening. You use almost 9 milliwatts per centimeter square at the center of the cone, and then you basically repeat in kind of 3 zones like that. Using photo-activated chromophores, etc., has been used for infectious keratitis. I think I won't go into that. Several riboflavins are also available. It can get very confusing. So luckily for us, we don't have many of them available. For all practical purposes, for most of our patients, we are using the riboflavin with HPMC in most of our cases, and basically are altering the protocols accordingly. So this slide I borrowed from Farhad Hafezi. The top right is the ones we really have evidence for. Everything else is still, we don't have enough evidence to say that it really works. So cross-linking, longer duration protocols are definitely more effective. With surface ablation or intracorneal range segments, it can be combined in selected cases to improve the uncorrected and best corrected visual acuity, especially in patients who are unlikely to be wearing lenses. PAC CXL is definitely something worth exploring for microbial keratitis, and there is some evidence to show that it helps in certain cases. Adapted fluence cross-linking, I think, has been a nice new addition for thinner corneas, so we are able to cross-link them now. And slit lamp cross-linking is something new which has come by Dr. Hafezi. He's introduced that, and I think that will help to make the procedure a little more accessible for people who don't have ORs or in peripheral areas. I think it should be very useful to our country. I hope one of the Indian companies develops something like this. Thank you. Sorry for overshooting a little bit.
Thank you, Dr. Rishi, and I request Dr. Vanati ma'am to give her comments.
I think, as Rishi rightly pointed out, 6 minutes is hardly anything to just breathe in and out Platin cross-linking. But I think there's a lot of hope in all the newer interventions and the newer recommendations, especially the sub 400 protocol. I think I still have not started using it. Any comments on that, Rishi?
I'm also not using the same. Yeah.
So I've been using it for almost 3 years, and it gives very good deep demarcation lines, sometimes deeper than you would like, but I've not had any patients who have ended up with edema or decompensation after that, so I think it's okay to use it. Yeah.
How thin do you go?
So
how thin do you go?
Earlier I was trying to go with the Hafezi protocol, but I realized that he's using a different riboflavin which doesn't have either HPMC or dextran.
Okay.
So we don't have that. So I've been now using the Narayan Netralaya one, and that seems to be working well with me.
And the thinnest pachymetry which you would use?
I have not gone below 250. Yeah. I'm using HPMC riboflavin, and I'm using the NN protocol. No. Exactly how it is.
Dr. Rishi, as you go thinner, what about the visual quality? And because we may be stabilizing the cornea, but such advanced keratoconus, what is the visual quality and how you are managing that part?
So ma'am, if we are going to be just doing a cross-linking, obviously if there's a lot of ectasia, you will not get a great outcome from the virgin cornea, but you can always wear a lens. If the patient is not going to be wearing a lens, then you have to consider some other options. Maybe you have to do some tissue addition or do a DALC instead of doing a cross-linking. I think it's a good idea to do a contact lens trial first before we do a cross-linking.
Thank you, ma'am. Next, I invite Dr. Geeta Iyer to give her talk on ocular surface squamous neoplasia, the preferred practice guidelines.
A very good morning. I'll be speaking on OSSN, a clinical-based approach to management. Why the focus on OSSN? We all know that OSSN is the most common of all ocular surface tumors, and especially with the onset of topical therapy for OSSN, there is a lack of clear guidelines for choosing management modality. What I'm going to do is, with the help of case scenarios, try and focus on what would be the preferred practice guidelines. Okay, so this is a patient of pigmented OSSN, diagnosed clinically and on AIOS, showing typical features on AIOS, for whom we initiated therapy with mitomycin C 0.04%. After 2 cycles, there was complete clinical resolution, and for the subclinical residual cells, we continued with 1 more cycle, and what you can see is a complete resolution of the lesion both on AIOS as well as clinically. So topical therapy definitely helps in the resolution of these lesions which are not involving the deeper layers. This is another case of pigmented OSSN that was treated with topical chemotherapy using mitomycin C, where you can see the complete resolution of the tumor. This is to highlight the AIOS features of OSSN, which is in the very characteristic that you note these features on AIOS, the hyperreflective epithelium, the abrupt transition between the normal epithelium and the involved epithelium, and significant thickening of the epithelium. And unlike the earlier 2 cases where we used topical mitomycin, this was a patient in whom we used topical interferon, and you can see the complete response in 6 months. So we have 2 options, topical therapy or immunotherapy using interferon, and you have chemotherapy using either mitomycin C or 5-FU, and any topical agent can be the first choice of preference. Usually it is preferable to stick to it as the first choice for all your cases unless it is contraindicated. This is the second scenario where we will briefly touch upon the chemo reduction aspect, where when you have a very large lesion which is involving a significant amount of the limbus and you don't want to end up with a limbal deficiency following surgical excision, then what is usually done is you treat them using topical therapy, chemo reduce the lesion, and then for whatever residual lesion is left behind, you go ahead with a surgical excision. So this is basically what constitutes chemo reduction or immunoreduction in these eyes. Chemo adjuvant therapy is when you do a surgical excision, and then based on the histopathological report, this was a patient where we went ahead with a surgical excision because it was a non-mobile lesion. So these are lesions where you do not want to initiate topical chemotherapy when it is relatively localized and less than 6 clock hours. So we did a surgical excision, and then since the margin was positive for CIN, we initiated this patient on topical chemotherapy post-operatively, 2 cycles of mitomycin C, and this was a patient who developed a toxicity with mitomycin C. So always when you are prescribing mitomycin C in these patients, you combine it with loteprednol throughout the course of the treatment, identify toxicity, stop, reassess, and change the plan if required. So scenario 4 is surgical excision, which is still the gold standard as far as OSSN is concerned. It provides you with quick resolution and diagnostic treatment, but it can leave residual unrecognized disease, and there is a risk of LSCD scarring and cryo effects or infection. The classical no-touch technique is what is followed, and you need to ensure that the surgical techniques and principles of wide margin excision, no-touch technique, alcohol corneal epithelectomy with a dry field, and a double freeze thaw cryotherapy to the conjunctival edge and the base if required is what is routinely followed. When you do a surgical excision, you will always have the benefit of having a histopathological diagnosis to the lesion. Unlike a surgical excision, the pros of topical therapy are that it treats the entire ocular surface, both the microscopic and the subclinical lesions. reduced limbal stem cell deficiency changes. But the cons of topical therapy primarily is the fact that you do not have a histopathological diagnosis, and it primarily treats the CIN component and not the squamous cell carcinoma component. This is a slide that I usually like to show, which compares all the three topical therapies across the various parameters: the mechanism of action, the compliance, need for refrigeration, the actual dosage and the drug holiday, and even the cost as far as the Indian scenario is concerned. And like I mentioned earlier, any one of these agents can be used as the first choice, and then you change over if you do not see a response in 6 to 8 weeks or with interferon or 2 cycles with mitomycin C. You should change your plan. You do not continue with the topical therapy forever. Clinical resolution, once you see clinical resolution, you still have to continue your topical therapy as indicated here for a period beyond clinical resolution. This is to treat the subclinical disease. And just to mention that chemo prevention is something that we now do in all patients of xeroderma pigmentosa, where interferon is continued 2 times a day indefinitely as a form of prevention. Scenario 5 is the use of AIOS in patients with very large lesions, and this definitely has a role to reduce the risk of limbal stem cell deficiency as well as the severity of symblepharon that you can see in these patients. Scenario 6, which is especially very important, is when you are unsure of the diagnosis. You never subject the patient to topical therapy. Always go ahead with an excision so that you have a histopathological diagnosis to know what exactly that it is that you are dealing with. And these are patients that you do not normally subject to a topical therapy. So this slide again clearly explains what are the contraindications and what are the indications for topical therapy. What is important is to explain to the patient very clearly that they do have both the choices. Unless it's a very large lesion where you want to chemo reduce, it's ultimately the patient's decision to choose topical therapy versus surgical excision. Also, you need to take that decision based on the your judgment of the patient's compliance as well as the patient's follow-up with you. If you're dealing with a very large lesion or a multifocal lesion, then topical therapy would be the way to go. So in summary, you triage your patient properly. Choice of topical agent, as I mentioned, could be any. Stick to it as your first choice, and follow the principles of surgical management, as well as know when you need to stop when you're treating the patient with topical therapy. Thank you.
Thank you, ma'am, for your talk. I would like to ask comments from Dr. Quresh Muscati, sir, on this.
No, I think Geeta has fairly extensively covered in the few minutes that she had at her disposal the various, and I think every case is different, and from your experience, as she correctly said, stick to whatever agent you're happy with. Don't flit between MMC and 5FU and interferon randomly. Thank you.
Can I? Hi, Geeta. Something which is now being, I think it's been on for quite a while, the role of plaque therapy in management of OSSN, and when would you like to use an interferon injections versus topical in OSSN managements?
Yeah, so interferon injection is something that we have used in a few of our patients, especially if you feel that they would not be compliant enough to use the medications on a regular basis. That would be one, but you also need to be aware of the fact that these patients can develop a flu-like symptom after the injection is given. Based on the dose that you're injecting, you either do weekly injections or monthly injections up to a maximum of 18 million international units. And as far as plaque therapy is concerned, if you do have scleral involvement, then normally what we do is we go ahead with a shave excision, and for the residual lesion, we subject the patient to plaque therapy. We, as of now, do not have access to plaque therapy, so we refer the patients across for the plaque therapy in situations where you still have a scleral involvement following your excision of the lesion. Thank you.
Thank you. We go on to our next speaker, Dr. Shreyash Ramurthy, who's a consultant at Cataract, Cornea and Refractive at Eye Foundation Group. I'm sure you know him well. He's going to talk on ocular cicatricial pemphigoid clinical approach and options, preferred practice guidelines. What happened?
No, you said, I think I know him well, so.
No, I said, I
No,
think all of you know him
he's
well.
just
Did I say that?
He's joking, he's joking.
Huh?
No,
We know him well.
She was careful, she is still learning.
Yes, sir. No, sir. Thank you so much, everyone. So, today I'm here to talk about ocular cicatricial pemphigoid, and I'll just throw some highlights of it in a brief manner in the time available, and also through some brief cases try to highlight important points. So with OCP, I think the most and important thing is to make the diagnosis as early as possible. And once we have made the diagnosis, arresting progression of the disease becomes most important, because it's only in the earlier stages why if we rehabilitate them, they have the best outcomes, because once they reach the later stages, it becomes very difficult to rehabilitate these patients. Often during the course of the management, you will have exacerbations and you need to be equipped to address the complications. So this is how I'll briefly take the overview. So ocular cicatricial pemphigoid is, or nowadays more than it's a subset of a systemic MMP, and it is classified by the linear deposits of these immunoglobulins IgG, IgA and complement C3 in the epithelial basement membrane. It's important to know at least the most common DDs, like post SJS, post adenoviral. Some of them can have, after a severe this thing, can have subconjunctival scarring, symblepharon. Pseudopemphigoid, drug induced, most commonly after anti-glaucoma medication. The reason that we have to differentiate them, because the line of management becomes very, very different. So that is one reason why we need to know some of the salient DD at least. OCP diagnosis is predominantly clinical, although HPE also is supportive in the diagnosis. And the main challenge with OCP is very often the chronic red eye is gets treated differently as conjunctivitis, allergy, and is often missed, and the diagnosis is delayed. In fact, studies by Foster's group have shown that more than 86% of patients have 50% or more of fornical shortening at the time of diagnosis, and the mean duration of the initial onset of symptoms to diagnosis is 2.8 years. So this very, very long lead time is essentially because of the relatively lower knowledge of OCP and diagnosis of OCP in the general ophthalmologist. So OCP is being a clinical diagnosis that you are looking at the typical features in the tarsal and fornical conjunctiva. Look for early symblepharon, and any chronically inflamed surface in an older patient, definitely suspect OCP. Stage 1 is the subconjunctival fibrosis and bands which you see, which is very, very important to identify at this stage. Even if it gets missed, at least at the early fornical shortening at stage 2, if we identify the patients in this stage 1 or 2 and immediately start and keep them on treatment and regular monitoring, we are able to achieve reasonable outcomes. But once it starts progressing into symblephara and progressive symblephara and ankyloblepharon and surface failures, it becomes very difficult to manage these patients. Documenting with serial slit lamp photographs is one of the best indicators of disease progression or activity. While biopsies are useful, some of the ways where, because the range of positivity depending on the study which you are seeing varies from 22 to 75%. And some of the ways we can increase the yield of positivity is by including the conjunctiva just adjacent to the inflamed conjunctiva. You could add immunoperoxidase techniques, which has been proven to show increase the yield. And there are some papers which even say that some of the biopsy negative OCPs probably have an even more aggressive course. So it's really, once you have diagnosed OCP clinically and you're seeing you have to initiate treatment immediately. While dapsone is there in many papers, I think more often than not, methotrexate, azathioprine in mild disease is started. Moderate disease, mycophenolate mofetil is very good. The side effects are very less, can be tolerated and can be used over a long period. And these are treatments easily which we as ophthalmologists can initiate and monitor these patients, and you don't really have to rely on a rheumatologist or an internist. Later stages, once it goes to a very severe disease where a requirement of cyclophosphamide, rituximab, IVIG is required, you would have to involve an immunologist or internist, but at the same time, you will have to convince them, because very often a rheumatologist, by just looking at a red eye, will not be willing to start cyclophosphamide for the patient. So highlighting the importance of starting it for these patients is very, very important. I think going into the individual side effects and this thing of each of these drugs would be beyond the scope of this time. But documenting progression, like I said, is best indicator. Once you have achieved remission, continue the treatment for at least a period of 1 year. And once you have achieved remission, we can consider visual rehab. Now, just achieving remission alone can improve clarity, and some of these patients, if they have adequate phonesis, can be fitted with a scleral contact lens and they do quite well. Some of these patients, once again you achieve remission, in that window period when you have a relatively clear cornea, do a early cataract surgery after 12 weeks. Because again, once a subsequent remission comes, a cataract surgery can become quite difficult. Your techniques may have to change. You might not be able to put in a speculum. Using traction sutures, all other techniques would be required. And you could also do a phonics reconstruction to fit them with scleral contact lenses, either with mucous membrane grafts or conjunctival autografts, once you have achieved complete remission and the disease is under control. Alloslate in OCP to be used very, very carefully in very select cases where the eyes are relatively wet. Anyway, these patients are on immunosuppression, and the immunosuppression will be continued even after alloslate. Alloslate is not going to be a final treatment for these cases. It's just buying us a little bit more time before an eventual K-Pro for these patients. Just an example of a wet eye where you have a significant pannus which has grown and you can do it. You may have acute exacerbations during the course of the disease leading to corneal perforations, and you have to either treat them with tissue adhesive cyanoacrylate glue or Tenon patch grafts. And once you step up the immunosuppression and treat the acute exacerbations, you can still go back to scleral contact lenses. Again, a bilateral acute exacerbation in a patient which had to be managed very aggressively with IV cyclophosphamide and IV methylprednisolone, use tarsorafis, other techniques to ensure that you can save the eye and achieve remission with these drugs. Then you can later, in these kind of surfaces where it's a very dry surface, there's significant keratin and complete ocular surface failure, you could do either a type 2 K-Pro, OOKP, modified LVP K-Pros as staged procedures. Of course, these patients all require long-term follow-up. These are challenging cases to handle. Very often you will, during the course of post-op management, have challenges like focal mucosal melts. You have to combine them with MMG immunomodulation tarsorafis. They develop glaucoma. You could do a valve as a primary procedure, or secondarily after lifting the mucosal flap and do a glaucoma drainage device. So these are really long-term managements, and various options are necessary, multitude of options to treat these patients. It's a wide spectrum, the OCP, from a mild to a very advanced disease. It's really early diagnosis and prompt initiation of therapy, and combination of these surface procedures with immunosuppression can give promising results. Thank you so much for your kind attention.
Very good talk, very well covered. Is there any role for a biopsy in these cases? Because it's seen easily, you can clinically itself you can evaluate in most cases.
I think there's a definite role for biopsy. I was not trying to say biopsy is not important. I meant there is, depending on the quality of the lab that you have available, the positivity rates can vary significantly. Multiple studies have shown a wide variety in the positivity rates. But even if you get a biopsy negative, but clinically all the features of OCP are there, we would still initiate aggressive therapy and not wait for the biopsy to be positive before we initiate systemic immunomodulation.
In fact, Shreyas mentioned, I think also that biopsy negative patients have a worse prognosis and a worse clinical features.
Thank you.
Some cases what we have clinically suspected OCP, biopsy came as lichen planus. Will exactly mimic the same, but of course therapy also will be almost same,
similar,
but they are lichen planus.
Yes, ma'am.
Thank you very much, Shreyas. We go on to our next speaker, Dr. Shrish Kumar, who is the medical superintendent of the Eye Foundation group of hospitals, and he is going to be talking on DALC, choosing the right technique for the right case. On to you. Thanks, Dr. Geeta. Thank you very much. Thanks for everything. Support through. Thank you.
My talk is on DALC, the right technique for the right case, preferred practice guidelines. So we all know keratoconus is one of the commonest indication for DALK, and these are some of the
6
indications.
minutes. It's written as
Some of the
5.
indications for keratoplasty in keratoconus. I'm not going into the details of these. These are the preferred surgical techniques. The preferred surgical technique is the big bubble technique, which was described by Anwar and Tikman. And manual layer by layer technique is the fallback technique. We should know this technique. Whenever there is a complication, we can always go back and continue with the DALK using this technique. So whenever we inject air bubble into the stroma, we get one of these 3 types of bubbles, type 1, type 2 and type 3 bubble. Type 1 bubble is also called white margin bubble. It is a strong bubble, and whenever you get a type 1 bubble, the chances of perforation is less. And this is the type 2 bubble. You can see a thin margin bubble, or it's a clear margin bubble. The chances of perforation with type 2 bubble is maximum. And type 3 bubble is a mixture of type 1 and type 2 bubble, and the perforation chances are more with the type 2 and type 3 bubbles. And this is a demonstration of type 1 bubble. You can see it's a white margin bubble, and the floor of this bubble, it contains Duas layer as well as Descemet's layer and endothelium, and the thickness is around 30 microns, and it's a strong bubble. The chances of perforation is less with this. And you can even inject air bubble into the antechamber to make sure that your bubble is formed, which the bubble, it displaces the bubble in the antechamber to the periphery. So it's a clear indication that there is a nice bubble which is formed. This is just a few cases. This is one particular case with the visual acuity of 6/60, 12 years old boy, and this is the topography of the patient. Thinnest corneal thickness is 271 and high astigmatism. This is a clear-cut case of DALK. It's an indication for DALK. And this is how I do, and it's actually a big bubble, and I usually do a superficial lamellar keratectomy initially, and then collapse the bubble using a 11 number blade, and then inject visco into the neck incision to keep the Descemet's away from all the manipulations. I use a blunt tipped venous scissor to cut the posterior lamella into 4 or 5 segments and till the periphery, and then I prepare my donor's tissue and place the graft on the host and suture it. I usually put 16 interrupted sutures if the size of the graft is more than 8 millimeters. If it is less than 8 millimeters, I usually put 12 sutures. And coming to type 2 bubble, we should know the types of bubbles, and clearly and accordingly you can change your surgical plan. And this is a nice big bubble which is around 10 millimeters in size, diameter, and you should identify this if at all you get this during surgery. And there is a classification based on OCT. It's a thorough preoperative evaluation of these patients, slit lamp evaluation as well as OCT evaluation has to be done to identify the stage of the condition. The keratoconus is divided into 5 stages, and the up to 3A, stage 3A. Stage 3A is like there is epithelial thickening and stromal thinning. There is no opacification as such in the stroma. So up to 3A you can safely go ahead and do a big bubble DALK, and beyond that 3B onwards, that is 5A, 5B is that is acute hydrops, and 5B is healed hydrops. These are the stages wherein it's very difficult to get a type 1 bubble, and you end up with a type 2 bubble. In such cases you have to go ahead with the manual DALK. And this is our publication, the complications in deep antilamellar keratoplasty. It was published last year. We also found that the perforation is more common with the type 2 bubble and the type 3 bubble. And another publication recently this year, it was published in OJO. It's from our center only. And again, the perforation is more common with the type 3 bubble and type 2 bubbles, and those who are having a deep stromal scar, the chances of perforation is more. A case of scarred cornea. This is a case of advanced keratoconus, and you have a deep scar extending up to the posterior stroma, and this is a case for DALK. Of course, one should be very careful while doing DALK in this particular case. This is how it went. You end up getting a type 2 bubble. You carefully observe here, it is a type 2 bubble. You notice this bubble, and then instead of doing a big bubble technique, you go ahead and do a manual technique so that you can avoid perforation, you can continue with your DALK. So that's what has been done here. The patient ended up with a manual DALK. Another case of healed hydrops. This is a healed hydrops case. This is a OCT picture of the same patient and a pentacam picture. And I went ahead with the manual DALK in this particular patient. If the scar is paracentral, you can safely go ahead. I usually inject air bubble into the stroma to create emphysema. Actually, of course, this is not advised. Many surgeons won't follow this, but this actually particular technique I am comfortable with. I do a manual DALK, I go right up to the pre-descemet's layer. These small multiple bubbles, they act as a guide, and I just stop short of these small bubbles, and that suggests I am in the right plane, that is in the pre-descemetic layer. Without perforation, you can continue with the DALK. It is repeatable, and you can do it in all the cases. This is the post-operative picture, day 1 and 6 weeks and 6 months post-operative picture. You can see a thin area of opacification around the perforation. This is the pre-operative and post-operative picture of the same patient. And advanced cases with the DM scar, again this is a healed hydrops. This is how it is post-operatively, the DALK. You can see a perforated area here, but it has sealed very well. So DALK can be performed in these cases. In spite of having perforations, you can continue with the DALK. Manual DALK is a savior. You can always learn to do this particular procedure. Conclusion is the surgical management of keratoconus. We have to identify the stage of keratoconus and then plan either a big bubble DALK or a manual DALK. So this is actually an algorithm for performing DALK, taking advantage of preoperative OCT. If the keratoconus is stage 1, 2 or 3A, you can go ahead with the do a deep refination, just start of 100 microns from the thinnest peripheral corneal point, and do a big bubble DALK. If that is not possible, then you can go ahead with other techniques like a manual dissection or visco dissection. And if there is intraoperative OCT which is available, it's good. But if you don't have, still you can safely go ahead and do your DALK. Thank you very much.
Thank you, Dr. Shrish. One very simple question to Dr. Revati. The post-operatively, the patient has a double anterior chamber. So what would you do immediately?
Yeah, usually we used to warn them also before surgery. You may need immediately also few sittings, and unless it is a very shallow double anterior chamber, we are sure we'll wait if there is no perforation. But otherwise, it's better to go in and do air bubbling and observe, because this case is advanced. And yesterday, Dr. Vanati, I think, mentioned better to go for a 0.5 larger graft, as in the regular PKP, than the same sex graft or less, because that will also reduce this chance for double AC without perforation.
Do most of these challenges get obviated, Dr. Vanati, with an IOCT?
I think an IOCT is an added advantage, especially if you are probably assisting your residents and fellows in a training program. It helps to minimize the intraoperative events here. That's it, and I think we all trained without the availability of an IOCT. So we are still adept at doing the same whenever we are doing it.
Okay, thank you. We go on to our next speaker. Thank you, Shrish. Dr. Sayan Basu, who needs no introduction, and he is going to talk on keratoprosthesis, current indications and techniques and preferred practice guidelines.
So
thank you, Dr. Sayan, for having supported me for innumerable programs in my ARC. Thank you so much.
It was an absolute pleasure, ma'am, and thank you for making me a part of this session as well. So I have a very simple topic to talk on: preferred practice patterns. The original topic was preferred practice patterns for keratoprosthesis. That is a very short topic for me to speak on, because the preferred practice for keratoprosthesis should be that unless you are in a very large institute where you have great retina and glaucoma backup, don't do a keratoprosthesis. If you have a patient who needs a keratoprosthesis, send that patient to an institute where they can do a keratoprosthesis. So I changed that a little bit so that we have a little bit to talk about, and made it about, if you have an indication like bilateral limbal stem cell deficiency, then how do you decide between doing an AIOS and a keratoprosthesis, which is more relatable and clinically would be more useful to discuss, and we can then build the preferred practice pattern around it. So this is the general algorithm that I think most people follow. It's very intuitive, and it helps you to understand where you do what. So if you have a case of unilateral limbal stem cell deficiency, it might be chemical burns, it might be any other cause, but mostly unilateral LSCD is chemical burns. And there is visual potential in that eye, and the eye has a wet surface, then this is where you would think about doing an autologous limbal stem cell transplantation, which is basically an autologous sled from the other eye, and you would wait for the corneal stroma to clear over time. If you have a dry surface, unilateral, we usually don't do anything for these patients. It's important to emphasize here that these are not cases where you would do a keratoprosthesis. So typically we discourage people from doing keratoprosthesis if it's only in one eye. In bilateral LSCD, you're more desperate, the patient needs vision, and therefore in these cases your options are more complicated. Either you can do an allogenic limbal stem cell transplant, which is where an allosled comes in, along with a keratoplasty, along with systemic immunosuppression, or you can do a Boston type 1 K-pro if the eye is wet, or more complicated forms of K-pro like the MO KP, the type 2, the LVP K-pro like Shreya showed, or Lux keratoprosthesis, which is also available now, where the surface is dry. If there is no visual potential, again, in either case, you will not do any surgical intervention. So if you look at the causes of bilateral LSCD, chemical burns is #1 cause, and then you have allergic eye disease in India, SJS and pemphigoid. Now, these are two very useful articles to understand what is the logic that you use. One is in the ocular surface, which is a surgical management of bilateral limbal stem cell deficiency, which basically shows that the outcomes of keratoprosthesis are good in the short term, but not sustainable over a very long period of time, unless you are able to change or exchange the keratoprosthesis. Whereas the visual outcomes in limbal stem cell transplant is more sustainable, but not as impressive initially as a keratoprosthesis. So the absolute benefit you get in terms of what the patient sees is much greater in keratoprosthesis, but the duration for which they have that benefit is shorter. And the other problem with keratoprosthesis is that the risk of complications, especially severe vision-threatening complications, is very high. So, and this is basically why you have to be very choosy about doing keratoprosthesis, and as well you have to have the backup to manage these complications, which are mostly surface-related, cornea-related, infection-related, but also could be glaucoma, which almost happens in 40 to 50% of patients, and also posterior segment complications like retinal detachments or endophthalmitis, where you would need the help of a retinal surgeon. So you need to have that team. So keratoprosthesis practice can never be just a cornea practice alone. It is always in combination with a glaucoma and a retina practitioner as well. So that is something that you need to keep in mind, and that is why it is difficult. So the basic way that you differentiate whether you want to do a keratoprosthesis or an allosled is basically based on stromal clarity. So The infrared image of an anterior segment OCT comes in really handy, which tells you whether you can visualize, like you can see in these first two images, the pupillary margin or not, or whether it is completely opaque, where you can see on the line scan also that the cornea is extremely edematous and opaque. And there you cannot do a slit, you have to do a keratoprosthesis. So ideally for slit, the underlying stromal clarity should be clear, and then you can take an allogenic graft from a donor. So here I'll just show you a short surgical video before concluding and what we typically do for allogenic slit, which is basically very similar to autologous slit. You remove the pannus, you put an amniotic membrane around with fibrin glue and glue it onto the ocular surface, and then we take a biopsy from a cadaveric limbus. Here we are taking it from a corneoscleral limb. You can also use a live biopsy, living biopsy from a donor, and this is then cut into small pieces and then pasted on the ocular surface. So you can have a patient which has severe limbal stem cell deficiency and a very aggressive looking pannus on the surface. This is a patient with bilateral LSCD due to chronic allergy, which looks like this preoperatively, and treat that patient with allogenic slit and get an outcome like this. This is the same patient post-operatively at 2 years with systemic immunosuppression with scleral lenses seeing 20/20, which is sustainable if you can give that patient that treatment. And it's not as if things can't go wrong in alloslit. You can have rejection, and therefore continuing systemic immunosuppression is important. You can also have progressive recurrence of LSCD where you might have to repeat the procedure. And there is also the risk of herpetic infections because of the systemic immunosuppression. So key messages, both these options are available for bilateral LSCD. If you have adnexal damage, dry eye, symblepharon, corneal stromal damage, disorganized anterior segment, advanced cataract glaucoma where a slit is not possible or will not help, then you do a K-Pro. Otherwise, for all other indications, an allogenic slit will be useful. Again, I'll finish by saying that if you have a patient who fits this criteria suitable for K-Pro, send that patient to a place where they have glaucoma retina support and can manage this patient. Please do not do keratoprosthesis alone in private practice unless you're Dr. Muscati. He is the only exception. Thank you so much.
One question, would there be any point when you like to combine a K-Pro with the glaucoma drainage device too?
So typically, if the patient is a known case of glaucoma, if you have that history, or sometimes you do something called a diagnostic endoscopy to see if the nerve head is damaged, and if you have that information a priori, then typically we'll combine a shunt with a K-Pro. If you don't know whether the patient has glaucoma or not, then typically we just do the K-Pro and then evaluate, and then if required we can always go back and do a shunt later on. But it is true that a high proportion of patients will require a shunt.
Yeah, even my threshold for doing a shunt at the same time is very low. So if you do a B scan, you find cupping over there, or digital, the pressure is high in these patients, go ahead and do a shunt. It's much easier to do it at the time of the K-Pro than to wait and take serial optic nerve photographs and find it going down and then doing a shunt later on. And patients' acceptance is also high at the same time. Then you're subjecting to one more surgery, acceptance is a little low.
Is there any, how does a repeat K-Pro help at all?
Yeah, sometimes the K-Pro is extruded, sometimes there is infection, and we've all had to remove a Boston K-Pro, put a keratoplasty there, wait for the therapeutic PK to then wait for the infection to subside, and if all is well, you can go in again with a K-Pro. Prognosis not so great, but sometimes in a one eye there is no other choice.
I'll just say one thing, 10 seconds. Every keratoprosthesis will need to be replaced.
Yes.
The only question is, will you be in a situation where you can replace it in time so that the patient can sustain and retain that vision? That is where it is tricky.
Yeah.
No keratoprosthesis will stay in the eye forever.
Thank you so much, Dr. Sayan Basu. I'm sure there was a lot of pearls which the audience got to learn. We go on to the next presentation, last presentation for Dr. Rajesh Fogla, which is a recorded video because he couldn't change his flight timing. And his talk is on complications post-endothelial keratoplasty. I would be very obliged if the expert panel take up some relevant point and explain it. Increase the volume.
I have no financial interest to disclose. Endothelial keratoplasty, ESEC or EMEC, is currently the preferred surgical technique for managing endothelial disorders. Successful management of post-operative complications is essential to improve the surgical outcomes. This presentation will cover some of the common complications and its recommended treatment. One of the common complications that we see is graft detachment. It occurs more frequently with DMEC than with DSEC, usually seen in the first 1 to 2 weeks post-surgery after the air or gas has been completely absorbed. Why it occurs? Due to either inadequate air or gas tamponade, hypertony, interface debris or irregularity, external manipulation such as rubbing of the eye, poor endothelial cell function due to excessive manipulation of the donor or its reverse placement. Patient typically has decreased vision, persistent corneal edema, and partial or total separation of the donor disc. The diagnosis can be confirmed on slit lamp examination and by performing a corneal anterior segment OCT. Management usually involves rebubbling with air or gas bubble, followed by proper head positioning. And this is usually indicated in DMEC if there is progressive separation or the edema involves the central area or more than 30% of the surface area. How can you prevent it? By optimizing your surgical technique and avoiding excessive manipulation of the donor graft and ensuring that you have adequate tamponade for the initial postoperative period. The other common complication is intraocular pressure spikes. This can occur in the early or late postoperative period. Commonly in the early post-op, often it occurs because of pupillary block, because of the air or gas going behind the pupil and then resulting in peripheral anterior synechia and blockage of outflow. Patient can be a steroid responder, or there can be pre-existing glaucoma, or especially in conditions like ICE syndrome. With severe rise in pressure, you can have pain, redness, headache, vomiting, decreased vision, or sometimes the patient can be asymptomatic as well. The management involves use of topical or oral medications to reduce the intraocular pressure. And in prevention, yes, proper surgical technique, either keep the pupil dilated in the postoperative period, examine the patient 2 hours post-surgery, or intraoperatively you can perform an inferior peripheral iodectomy, which ensures that you don't get a pupillary block. The other complication that we are worried about is infection. It can occur because of viral, bacterial, or fungal etiology. If it occurs very early in the postoperative period, it could be because of donor contamination, and usually it's bacterial. In the late post-op period, you can get interface infections, which are typically from Candida, or it can be from a viral etiology as well. Typically, the patient will present with pain, redness, decrease in vision, and on slit lamp examination, you can observe these corneal infiltrates. You may require to do a microbiology to establish the organism and provide the appropriate antimicrobial therapy. Often it means that you have to remove the donor disc from the eye to eradicate the infection completely, although for small interface infiltrates, intrastromal antimicrobials have been attempted to try and resolve the infection. Again, proper surgical technique, avoid venting incisions, give adequate antibiotic prophylaxis, and always evaluate the donor tissue once you receive it from the eye bank for any change in the color of the medium or turbidity. Graft rejection is much lower compared to penetrating keratoplasty. It's the lowest with DMEC compared to DSEC. Again, the symptoms could be a decrease in vision, light sensitivity, pain, redness, and on slit lamp examination, you can see corneal edema and keratic precipitates. Often they are limited only to the donor disc. And if you see the keratic precipitates across the entire cornea, you have to differentiate from a viral endotheliitis. Sometimes epithelial ingrowth can also mimic a similar clinical picture, and interface opacities with keratic precipitates. Also, you need to think about infection. Once you diagnose that it's rejection, yes, the mainstay of treatment is using topical and systemic steroids. You may need to start the patient on immunosuppressive therapy for preventing future rejection episodes, and obviously these patients need a closer monitoring than your routine cases. Especially adequate immunosuppressive therapy should be given in high-risk graft such as patients with multiple transplants, systemic disease, or previous episodes of graft rejection. Primary graft failure is rare, but it can occur in the learning curve. Often it's due to a reverse placement of the donor graft or due to TM detachment, decreased vision, and persistent corneal edema, which is not resolving. It can be confirmed by looking at slit lamp examination and doing serial anterior segment OCT. If the graft does not clear for 8 to 12 weeks, you may have to consider exchanging the graft with a fresh donor tissue. And preventing, yes, you get good quality donor tissue from the eye bank with at least cell counts which are more than 2,400 or 2,500, and stamp the donor tissue on the stromal side to ensure correct orientation. Cystoid macular edema can occur in about 8 to 12% of cases undergoing endothelial keratoplasty. It can be pre-existing or it can occur in the postoperative period. Again, this can be when you have a clear graft but the patient vision doesn't improve appropriately. You have to perform a macular OCT, and if it's present, then you can treat with either topical NSAIDs, or sometimes you may have to refer to your retinal colleague for intravitreal or posterior subtenon steroids. And controlling the inflammation in the postoperative period may help avoid this problem. So basically, in conclusion, it's important to discuss with your patient undergoing endothelial keratoplasty about all these postoperative complications. Important to monitor the patient appropriately in the early postoperative period and intervene if you notice any of these complications. Future research, yes, it may reduce these complications by introducing newer surgical procedures such as cell-based therapy and newer diagnostic techniques like the use of femtosecond laser and the intraop OCT may help prevent some of these postoperative complications. Thank you. Thank you for a patient hearing.
Thank you very much. That comes to the end of this cornea session of preferred practice guidelines. I want to thank each and every one of you, the expert panel, and all the dear speakers for this most valuable time given to me. Do we take one tiny photograph, or are we running late?